All right, good morning and good afternoon. Today we're going to start talking about vital signs and how they play a part in the overall uh, pathophysiology and keeping us in that hemostatic dynamic. All right, so let's go and get started here. Find my PowerPoint. All right, vital signs. The vital signs include 4 different parameters: temperature, a patient's pulse rate, how fast or how slow a patient is breathing, their respirations, and blood pressure. Another one we can add in there, it's not your standard 4, but another one we can add in there is something known as pulse oximetry, or otherwise known as pulse ox. We'll talk more about that here in a little bit. Vital signs must be measured, reported, and recorded accurately. If you're not sure of a measurement, recheck it. This happens a lot, especially in emergency medicine. Sometimes like for example, blood pressure. Sometimes blood pressure is hard to hear, depending on the environment you're in. If you're in an environment where it's very loud outside and we're trying to listen to a blood pressure, then it can actually, especially if the blood pressure is low, it can be hard to hear. So it may take myself, it may take someone else in order to hear that blood pressure. I may hear it, but I may not have got the first number right. So I may have to do it again. So it's very important that when we check these vital signs, that they are accurate, because as we'll talk about here shortly, they all of them put together can tell us, give us a good example of what's going on with the patient, a good idea of what's going on, and depending on what the vital signs are, depends on the severity and of the whatever is going on with the patient and how quickly we need to react to that. If you are not sure of a measurement, recheck it. It's okay, especially for people who are brand new clinicians, for people who are brand new EMTs, paramedics, nurses, whatever. This is something you get better at by doing. Just like with most skills, vital sign taking is a skill. And so we do it, we get better at it by doing it over and over and over. And there's gonna be some times where you make mistakes. Correct your mistakes, find out what it is and correct it, okay? Just don't go, the pulse was 120, when in reality, it's 180, because those two things can tell us 2 different complete things about the patient. If we got a patient with a pulse rate of 180, and first of all, 180, that's probably too hard for us to even count manually. We'll get that when we put them on a pulse ox or put them on an EKG or something like that. But 180 is going to be hard. I mean, if you just feel the pulse just going spastic when you're palpating it, then we need to look further, because that patient may have a condition known as supraventricular tachycardia, or SVT, and there's several ways for us to treat that. We can shock them. We can shock their heart back into what's called a normal sinus rhythm, or we can give them drugs, which will slow their heart rate down. Okay, so we need to be accurate in our vital sign taking. When are vital signs taken? When a person is admitted to a healthcare facility. So typically, if you go in through the ER, when you go to the triage nurse, which is normally the first person you will see when you get to the ER, they'll take your vital signs, and that will be part of your patient chart. Okay. Several times a day for hospitalized patients. If you're in the hospital for any condition, depending on what the condition is and depending on what the doctor orders, there is time parameters as far as how often the nurse or the patient care techs or the paramedics or whoever is working in the hospital takes the vital signs. Okay. Sometimes it's every 4 hours, sometimes it's every 2 hours, sometimes it's every 8 hours. It depends on when the doctor asks for them to be taken. Before and after surgery. So we try to get a baseline in before surgery, and then we'll recheck after surgery. Now, while you're in surgery, they're constantly checking vitals. You're hooked up to different machines, and they will do it automatically. So it's just not during or before and after. It's also during surgery. They'll also monitor your vital signs, make sure that your heart rate is at a level of where it should be. Okay. After some nursing procedures, depending on what is being prescribed for you or what the doctor's orders are, the nurses may take your vital signs following a certain procedure or not. Okay. Before medications are given that affect the respiratory or circulatory system, because we're monitoring how fast or how slow you're breathing, we're monitoring how fast or how slow your pulse is, then we will take your vital signs before we give a specific drug that may interact with those vital signs, with those body systems. Because what we don't want to do is let's take blood pressure, for example. If you're having a high blood pressure crisis, meaning that your blood pressure, so let's say you're diagnosed with high blood pressure, or as known as hypertension. So you're diagnosed with hypertension, and you call 911, and we get there, and we take your blood pressure, and it's 180 over 100, okay, or 110. This is a very high blood pressure. Okay, this is something that we need to probably talk to a physician about, either through the ER or make sure you make an appointment with your personal care physician to possibly get put on high blood pressure meds, hypertension meds. So we can see from the vital signs that we take, especially your blood pressure, that yes, your blood pressure says 180 over 110. Now let's redo that scenario. You call 911, high blood pressure. As soon as you get off 911, you take blood pressure medication. I get there on scene, I take a blood pressure 130 over 80. Okay, perfect. So it's masking something that could be going on. So we want to try and take it while you're in that high phase, because you call 911 for a high blood pressure. We get there, your blood pressure is normal. And so it's masking something that might be going on. Okay. Whenever the person complains of pain, shortness of breath, rapid heart rate, or not feeling well, when we take vital signs, we do it almost on every patient. In my paramedic career, I would be hard pressed to come up with 5 people that I did not take vital signs on. Because it's something we do on every patient. They give us a baseline information of what could be going on with this patient. And so every patient that I saw, they had vitals taken. If anything, for my patient chart, because even though I get toned out, I may not be taken to the hospital, I still have to write a report up on it. And if I do not put that vital information in there, then I'm not doing my job as a clinician. And it's something ultimately I can get sued about. Say the patient, we respond to scene, the patient says, I just wanted you to look at me. I feel fine. I'm not going to go to the hospital. And say the vital signs are really, really high or really low, but I don't know that because I never took them. Okay. And so the patient's like, I don't want to go to hospital. Don't want to go to hospital. I'm fine. And we had them sign what's called against medical advice. So I had them sign what's called AMA. And I said, hey, listen, you need us, call us back. 2 hours later, the patient's wife calls. Patient is now unconscious, not breathing. Well, I get there. We start CPR, we load them up, take them to the hospital. A couple weeks later, I get notified that I'm part of a lawsuit. And now I got to I have to go to court and talk about why I didn't take this patient's vital signs. And ultimately, it's going to come back and haunt me. It's going to hurt me. I could lose my licensure as a paramedic. I could, more likely, I'm going to get fired because I was negligent in my duty. I did not do what's called the standard of care. I didn't do what 100 other medics would do in that situation, which is at least take the patient's vital signs. They can still refuse all they want, but at least I have baseline vitals, okay? So anytime a patient's complaining of anything or just not feeling well, you're gonna get vital signs taken. Think about it. When was the last time you went to a doctor and they did not take your vital sign? They didn't take a pulse. They didn't put the little cuff around your arm and take a blood pressure, okay? I can't think of one time. All right, even when I was a kid, they still took your vitals. With the person at rest in lying or sitting position. So we have something called, and we'll talk more about this, called orthostatic vital signs. And typically, orthostatic vital signs, what they'll tell us is if there's a decrease in fluid somewhere in the body. So say we have you sitting up, and I take your blood pressure, and it gives me one reading. I lie you down. I take your blood pressure, and it gives me a different reading, okay? This is what's called a positive orthostatic vital sign. This meaning that there is a fluid shift somewhere going on in the body. You could either be dehydrated, we can have fluid loss somewhere. You can be what's called hypovolemic, which means you are losing blood somewhere, okay? And we need to be concerned about that, okay? Typically, when we have a patient that's dehydrated, we'll see this a lot we'll see a positive orthostatic vital sign. And we'll talk more about orthostatic vital signs as we get going in this unit. Factors that affect vital signs. Illness. If you are sick, remember, you are out of homeostasis. So if you're sick, this can impact vital signs, okay? Especially fever. If you go into the doctor and you're running 104 fever, okay, your vital signs are not normal. That 104 is not a normal temperature. 98.6 is. All right, so if you're ill, this can impact vital signs. Emotions, anger, fear, anxiety, pain. All these can cause a shift in vital signs, whether it being increased blood pressure, being increased heart rate, meaning increase in respiratory. So anytime emotions get involved here, this has an impact on your vital signs. Okay, it's going to throw them a little out of whack. So we need to be aware of that. Someone that's having an anxiety attack, for example, are they breathing 16 times a minute? No. Chances are they're hyperventilating, which meaning they are probably their breath rate is probably anywhere from 28 to maybe 36 to 40. Okay, and they're not good deep breaths. They're very shallow. Okay, so this is a vital sign that's being impacted by an emotion. Anger will have a positive effect on our blood pressure and our pulse. Meaning, chances are our blood pressure is going to increase and our pulse rate is going to increase. All right, exercise and activity. Exercise and activity. Exercise initially will cause your heart rate to go up, because especially if you're doing aerobic exercises, it's also going to cause your breath rate to go up as well, your breathing rate. Any activity which gets you up and going, but that's not to say that's a bad thing. That's a good thing because we need to be more active. If you have a patient that lives a sedentary lifestyle, meaning that there's not a lot of activity there, they go to work, they come home, they lay on their couch or in the recliner, and the only time they get up is to go to the restroom or get something to eat, and then they go back and lay down, and they eat a high fatty diet, high cholesterol diet. And if you're doing that but not adding any exercise in, this can cause a problem. All right, so exercise and activity play a role in it, either too much of it or too little of it. If we have too little of exercise and activity, then we're dealing with obesity issues, which can also impact vital signs. Okay, so we'll talk more about that as well. Now, in regards to exercise and activity, so when we talk about vital signs, especially blood pressure, we use the number 120/80. Okay, this signifies a perfect blood pressure, 120/80. This is someone that is 18 to 21 years old, that has never smoked, never drank, is in okay physical condition. 120/80. Now, say you respond to a call of a marathon runner who isn't feeling well. You go take the vital signs. You find their blood pressure 110/60, maybe their pulse rate, instead of being 70 to 100, maybe it's around 52 to 54. And you're like, oh my gosh, something's going on with this patient. Their vital signs are low. No, that actually may be their normal. You need to ask them about that. What is your normal blood pressure? Because they're an endurance athlete. Typically, what we'll see in endurance athletes is they'll have lower vital signs than others. So we need to ask, one of the questions we need to ask the patient is, what's your blood pressure normally, or what's your pulse normally? And if they're giving you a low value, then when you take your vital signs and you get a low value around that same reading, it's not alarming, because that is their normal. Okay. So for example, say that same marathon runner, we respond to them and their normal blood pressure is anywhere between 100 and 110 over 50 to 60. Now you respond and you take their blood pressure and it's 130/100. Okay, now that's way out of whack for their normal. So something is going on there. So let's make sure that we're asking patients, what does your blood pressure normally run? All right, questions like that can really be helpful in trying to determine if there's something is going on with the patient. Age. Age will also have an impact on vital signs. Like I said, the normal heart or the normal pulse or blood pressure for a patient is 120/80. Pulse is anywhere from 70 to 100. Breath anywhere from 12 to 16 times a minute. Now, as we get older, this is going to change. Our blood pressure has a tendency to go up, and our pulse may go up or down as well. Now, also children, when you're 18 years old, your blood pressure and your pulse is not the same as it was when you were 4, 5, or 6 years old. Okay, when you were younger, your pulse rate was higher, your blood pressure was lower, and so as you get older, your body changes, and thus the vital signs change as well. So if you respond to a infant that has a blood pressure of 120/80, there's issues. There's something majorly going wrong. That patient is borderline critical. That is not a normal blood pressure for a patient of that age. Okay, so we need to be sure that we know the vital signs for different age groups. Sex, male and female, you will have a tendency to have a change or effect on vital signs depending on your sex. Just because of how the physiology of the body is, and how sometimes our bodies react to certain things depending on our sex. So therefore, sex can also impact vital signs. Environment, the weather can impact vital signs. For example, temperature. If we're talking about a patient that's hyperthermic or hypothermic, this has an impact on the temperature. So a patient that's hyperthermic, their temperature is going to be over 98.6. Okay, actually, it's probably going to be over 101, 102. If we're dealing with a patient that's hypothermic, we're dealing with a patient that's core temperature is below 95 degrees Fahrenheit. Okay, so weather, if we're outside in the cold, this can impact our temperature. We can become hypothermic if we are not, if we do not have the proper attire on, if we aren't covered up the way we should. If we're outside and it's 110 degrees and we're out running sprints, Well, and we're doing this without water, without taking breaks. Well, this can have a negative impact on our temperature as well. This can cause our body core temp to go up, okay, and lead us into heat exhaustion or possibly into heat stroke. Food and fluid intake. Um, if someone is not eating enough or drinking enough, their vital signs, first of all, they're becoming dehydrated and they're becoming malnourished. This can have a negative impact on vital signs. Excuse me. And so we could see a decrease in blood pressure, a decrease in pulse rate from this as well. So if we have a patient that say they've been ill, say they've had the stomach virus for 3 to 4 days, you get called, you arrive on scene, or say the patient is comes into the hospital and they've been throwing up constantly for the past 3 days. You expect their vital signs to be extremely out of norm here, out of whack, because they have not had any food intake in 3 to 4 days. Chances are they've not had any fluid, at least anything of impact. They've not had Gatorade, no water, anything like this, because they're scared. If they drink something or eat something, they're going to throw it back up. Think about the last time you suffered from a stomach virus. Did you want to eat? Did you want to drink? Chances are you didn't. So if you didn't, and you have not had anything substantial to drink in 3 to 4 days, your vital signs are going to show this. You're going to have probably an extremely low blood pressure, and we're probably going to have to give you some fluid. So chances are, if you call 911 or you go to the hospital, they're going to start an IV on you to try and rehydrate you. Okay, medications. I can talk for 12 hours about medications having an impact on vital signs and still would not be enough. Almost every medication out there can have an impact on vital signs. When you get prescribed a new medicine, you can talk to the pharmacist about it. You can talk to your doctor about it. But make sure that you know what impact it does have on especially blood pressure. Okay, time of day. Typically, we'll see a decrease in vital signs when you first wake up, and then as your day progresses, we'll see an increase in your vital signs. Think about it. You've been asleep for, say, let's say optimum. I know this is not many people out there, especially as teenagers, but let's say you got 8 hours of sleep, and you wake up, and your blood pressure is perfect because you've not dealt with any stress over the past 8 hours. You've been asleep. Your body's had time to relax and recover from the previous day. Now, as you move on with your day, life happens. You missed an assignment. You didn't do as well as you thought on a test. You found out your boyfriend or girlfriend may be breaking up with you. And all this stuff can increase your vital signs. Blood pressure goes up, heart rate goes up. Now you start feeling the anxiety, the fear. Maybe you're upset at a teacher or upset at a fellow classmate, your parent. It doesn't matter. All this will have an impact on your overall vital signs, and we will see an increase in that as day goes along. Now, one thing we'll see, and for those of you that want to practice emergency medicine at any level, you will experience this as well. You will see lots of chest pains and heart attacks first thing in the morning. Typically what's going on is a patient, especially as we get older, a patient could be lying down in bed and they sit up too fast and this plummets their blood pressure. Okay. Or they they wake up with chest pain. So typically we will see a lot of cardiac calls first thing in the morning. Noise can impact vital signs as well. Because think about it, noise can impact anxiety. If you're in a very loud environment, that could also be a very stressful environment. And when you have that, this can cause a change in vital signs as well. A change in one vital sign will cause a change in the other vital signs as well. Okay. Typically, we'll see a inverse reaction with certain vital signs. Okay, meaning that we'll see an increase in one, and at the same time, we'll see a decrease in another one. Okay. How do we document and notate vital signs? So the abbreviations we use for temperature is T, pulse is P, respirations R, and blood pressure BP. Okay, these are pretty standard throughout all practices. Body temperature is the amount of heat in the body. It is a balance between the amount of heat produced and the amount of heat lost. Okay, so once again, we are working on the 98.6 being the optimum temp. Okay, that's our baseline. Heat is produced by the contraction of muscles during exercise. So you produce heat by your muscles moving. Okay, the breakdown of food during digestion. This also produces heat throughout the body. The environmental temperature, the temperature that you are when you're that you're experiencing, whether it's inside a building or outside. Okay, if we're outside, then we're subject to whatever's going on outside. If it's hot and dry, our body core temp's going to go up. If we're outside and it's 42 degrees and misting, well, this will cause our body core temp to go down. Especially if we're wearing shorts and a t-shirt, and now our shorts and t-shirt are wet from the cold mist. This will greatly increase this will greatly decrease our body core temp, okay, and increase our rate or our chance of hypothermia. Heat is lost through urine, feces, respirations, and perspiration. Also, let's add another one on there. If you are lying on, so say it's wintertime here in Texas, and as you all know, in Texas, during the winter, it could be 12 degrees outside, or it could still be 60 degrees outside in winter. This is Texas weather. It varies. But if you have a patient that's lying on, say it's the air temperature is 28 degrees outside, you have a patient that is wearing just a long sleeve t-shirt and say blue jeans, and they're lying on the ground. Okay, heat can be lost through conduction. Okay, through us having contact with the ground. So therefore, we can lose heat this way as well. Okay, so just not through urine or through defecating or through breathing faster. Okay, hyperventilating or through sweating more. Okay, you can also lose it by coming in contact with something that is cold for a prolonged amount of time. Body temperature is measured in one of four areas of the body: orally, rectally, axillary, or tympanic. And as many of y'all know, we also have forehead one now, so really 5. Oral is probably the one we're most familiar with. Rectally, we see this a lot as infants, because you can't get an infant to hold a thermometer underneath their tongue. It's impossible. So we'll either take it rectally or axillary through the underarm. Tympanic, we see a lot of these in the clinical practice now, either through the temple or through the forehead, okay, or through the ear. Okay, most temperatures are taken orally. And we'll talk about this in a second. Rectal temperatures are the most accurate. That is because you're actually getting an accurate core temp. Think about it. Sticking a thermometer up the backside. Okay, we're actually going into the core. This is going to give us our best and the most accurate temp. However, we're also not going to do this a lot of time in the field. Okay, it's uncomfortable for you and for them, and it's not ideal, especially in pre-hospital setting, to have a patient take off their pants so you can take a rectal temp. Axillary temps are the least accurate. Okay, there's a lot of factors going in there. The probe on the end, not making straight contact to the skin, movement of the arm can shift it. So axillary temperatures underneath the armpit are the least accurate. Normal ranges. Orally, 97.6 to 99.6. Rectally, 98.6 to 106. 100.6. Axillary, 96 to 98.6. tympanic 98.6, temporal 98.6. Okay, most of us should be familiar with what normal temp values are. Reading a old school mercury thermometer. Okay, that's the one that looks like a little cylinder. You got to shake it to get the mercury down. Has a little silver tip on the end. The scale is marked from 94 to 108. If you have it under the tongue for 90 seconds to 2 minutes and the mercury has not moved, and you found this patient lying outside and we are in the dead part of winter, chances are this patient is hypothermic. So we need to go ahead and start warming measures on this patient. That can look anything like wrapping blankets around the patient. If we have what's called a silver swaddler, we can wrap a silver sheet around them. We can run warmed IV fluids into them. So there's different ways to try and warm up a patient, but we do this slowly. We don't take a patient from outside and throw them into a sauna immediately. This could cause them to have go into cardiac arrest. So when we warm a patient, we warm them slowly, okay, not quickly. The long lines represent 1 degree. The short lines represent 0.2 of a degree. Every other degree is marked with a number. Okay, so there on the picture, it shows us 98.6. All right, so it counts by twos, 2, 4, 6, 8, and that goes all the way through the whole length of the thermometer. This is typically what we'll see now in practice, whether it's emergency medicine, the hospital, care now. Typically the battery operated or AC operated, meaning plug into the wall. Have an oral probe and a rectal probe. Do not get these confused. All right, make sure you know which one is a rectal probe. Make sure you know which one is the oral probe. That could make the difference between your patient having a good day and a really, really horrible day if you do not get those right. You will always use disposable covers. Typically, these are hard and plastic. Sometimes it can be a thin paper plastic sheath that you just kind of the thermometer slides into. Most temperatures register in about 30 seconds on these machines. Sometimes actually it's a little bit less. And even we're starting to see even a shift from these, especially at your clinics like Care Now and and all these doc in the boxes. And we're seeing them shift now to more of your tympanic or your forehead temporal thermometers. This is what I was talking about. You got the little plastic sheath there that thermometer just slides into. I hate it. It always makes me feel like I'm choking and gagging whenever that goes in my mouth. I'm not a big fan of those. Disposable oral thermometers. I hate these things. I use these a lot on the ambulance, and especially here in Texas, what we would find is on our ambulance in the heat of summer, the little dots there you see that which will determine the temperature would actually stick to the paper. So when we go to pull the paper apart from the thermometer, it would actually stick to it. We didn't have these long. We all had the same problem with these. We hated these things. And so we just got rid of them. I'm not a big fan of these. Maybe it's different if you can keep it in a climate controlled environment, but in emergency medicine, at least out on an ambulance, we do not have that. So these were not very popular amongst us medics. Taking a temperature with a glass thermometer, remember the mercury one, rinse with cold water first. Check the thermometer for breaks and chips. The last thing we want to do is put a broken glass tube into someone's mouth. So make sure you inspect it. Make sure there's no cracks in it, especially anywhere where the mercury can be. Shake down the thermometer so the mercury is below the lines and numbers. Sometimes, depending on the environment, it can actually be a little high. So we want to make sure we shake that down until it goes all the way down. Place of disposable cover on the thermometer. Once again, you put a little plastic disposable cover on there and then insert it into the patient's mouth under the tongue. Have them have it in there for 2 to 3 minutes, and then you'll pull it out. You'll check it and see what it says. If a person has eaten anything, drank anything, or smoked beforehand, wait 15 minutes since the last time they did any of those activities to take a temperature. Think about it. Cigarette smoke is warm. That has a tendency to increase the mouth temperature, the temperature in the mouth, and that can give you a false reading. Okay. Same with drinking a cold fluid. Okay. So let's try and wait 15 minutes before we take a oral temperature using a old style glass thermometer. The pulse. Every time the heart beats, this sends a shoot of blood through the body. So every time the heart contracts, it's shunting blood out into the system. Every time it does that, we feel a thump. That is a pulse. Okay, that's felt on the artery. We can even hear it. If I put the stethoscope up to where the indentions are in the neck, I can hear your carotid artery. If I can hear blockage in it. I can hear a delay in it. And so, and so this can also tell us valuable information about the carotid health of a patient. Okay. The pulse is felt every time the heart beats. So every time the heart contracts, we feel a pulse. It's more easily felt in arteries that come close to the skin and can be gently pushed against the bone. So the one we use most common is the radial pulse. We call it the radial pulse because it runs alongside the radius of the arm. Okay, so you feel it by pressing that artery against the bone, and we can feel the thump against our fingers, and that will give us what the pulse rate is. Okay. So on the forearm and on, you got the radius and the ulna, the two bones that form the forearm. And so we are pressing on the radial pulse, pressing against the radius bone. Okay. The pulse should be the same in all pulse sites on the body. So if I take a carotid pulse, meaning I'm placing my two fingers in the indention of the neck and I feel the pulse there, I should be able to come down to the radial artery and feel the same pulse. I should be able to also go down to the brachial artery in the part of the arm closest to the body, where your bicep is. I should be able to feel the brachial pulse there, and I should be able to go down to the inner thigh and feel the femoral pulse, and it should all feel the same. If there is a change in anyone, there's something going on in the patient that we need to be aware of. Okay, I'm gonna go ahead and stop there for today and open this up now to any questions.